Hello and welcome to Module 3 of Ombudsman Associate Certification Training. Today in Module 3, we're going to talk all about long-term care services and supports. This presentation is roughly 2 hours long. Module 3 is all about long-term care settings and resident rights. In this module, we'll learn about laws governing long-term care facilities, level of care, person-centered care, regulatory processes and procedures, and grievance councils. The module does cover a lot of information, so we'll have several learning objectives. With introductory knowledge of different long-term care settings, you'll be able to notice more that you might than if you walked into a nursing home now, and you'll be able to help residents participate in the regulatory process. We will also talk about care assessments, care planning, discharge and transfer planning, and be able to identify issues pertaining to those transitions. Our advocacy is grounded in a person-centered approach to care and the resident-focused perspective of the office. You will learn the role of resident and family councils so you can engage with them. Then, last, we'll wrap up with a brief overview of the Ombudsman role in home and community-based services. You'll talk with residents who are going home, and we want them to know that they can call us for help if they have any trouble with home care services they might receive. For Section 1, this is an overview of long-term care settings and also talks about selection assistance that we can provide as Ombudsman. So there are 5 types of long-term care facilities that we as Ombudsman provide services in. We'll go over each one of them in greater detail, but the 5 of them are nursing homes, county homes, long-term care acute hospitals, residential care facilities, aka assisted livings, and residential facilities class 2, aka group homes. Sometimes referred to as skilled nursing. Nursing homes accommodate residents who have higher level of care needs. There are just about 1,000 nursing homes in Ohio, and nursing homes serve residents needing more services than those that might be available through home care, assisted living, and other options. And although many people can get similar care in those other settings through the programs called waivers, we'll talk about those, nursing homes do not necessarily mean long-term care. More than half of all nursing home stays are for 3 months or less. And increasingly, nursing homes are used to complement and supplement other care options, including assisted living, hospital and home care, particularly for short-term rehabilitation, like after surgery. There are also different types of nursing homes. About 20% of all nursing homes in Ohio are not-for-profit homes, meaning they're privately owned by a not-for-profit organization. The largest group of nursing homes is the private for-profit nursing homes. These for-profit homes are often corporate-owned and make up approximately 80% of all nursing homes in Ohio. Many are owned by corporations that operate several homes, and some of these companies own homes across many states and are even publicly traded on the stock market. Most Ohio nursing homes are private for profit, which is about 80%. Just about 19% are not-for-profit, and another 1 to 2% are government-owned. Think of these like veteran homes or county homes. The Ohio Department of Health, or ODH, licenses and certifies nursing homes and also conducts their on-site inspections, called surveys, for compliance with state and federal regulations. All nursing homes must be licensed in Ohio, but certification is a voluntary process that allows the nursing homes to receive Medicaid and Medicare payment. Most nursing homes in Ohio are certified for that, and ODH controls the number of beds and homes in each county through a complicated process when facilities buy and sell. Residents who require a nursing home level of care might need help with things such as activities of daily living, like grooming, using the restroom, eating, drinking, or bathing. They might need help with mobility, with getting in and out of bed, and they might need help with medication, whether that's taking the meds on time, the correct dosage of medication, administration of that medication, as well as storage. Nursing home residents may receive additional medical care and therapy. Some are in the facility for short-term rehabilitation after a stay in the hospital. For example, someone who just had hip surgery might go to a nursing home to receive physical therapy for a short time before moving back home. Other therapies are offered in nursing homes as well, such as respiratory therapy, speech therapy, and occupational therapy. Some nursing homes have entire units dedicated to specialized medical care. Two of the most common units are the dialysis unit and a ventilator unit. For both of these types of units, the administration for the facility must apply to become a provider. You might also come across dementia units or locked units in nursing home, and it's important to know that there are not accreditations, certifications, or specific standards for training required in this state with facilities with those units. And then that brings us to the second bullet point on the screen for payer sources. Before the Social Security Act and the rise of Medicare and Medicaid, there was no real money to be made in the long-term care industry, so older people were being cared for by their families and county-operated homes. Times have certainly changed, and while most residents receive care at home or age in place at home, there are a lot more government-funded social assistance programs that might help residents pay for long-term care. This is why the nursing home industry has really grown, and to maximize federal reimbursement, Ohio has required that facilities that accept payment from Medicaid also must take payment from Medicare. We'll learn more about the specifics of those programs in a later module, but the basics are that Medicaid is a joint state and federal program that helps low-income people afford medical care. Most people think of Medicaid as being for very low-income people, but the standards are different for nursing home care, and most people can't afford to live in a nursing home very long before needing to apply for Medicaid. Medicare is a federal program that offers insurance benefits to people over the age of 65. Medicare does not pay for long-term care. It only pays for short-term skilled care. MyCare Ohio, which we currently do not have in Region 9, is in a special demonstration period. This is available to certain people who are dually eligible for Medicaid and Medicare and live in a MyCare region of the state, and it can also help pay for nursing home care. So those are the two main ways that residents pay for long-term care. However, they can also pay privately or with long-term care insurance. This means that they're using their own money to pay for the long-term care services and otherwise is known as private pay or paying out of pocket. Not all counties have county homes, and government-owned homes account for just about 2% of the homes in Ohio. County homes were the government-owned forerunners to nursing homes, and these homes served people with low incomes who required care but didn't have family to assist them. There are actually fewer than 20 of these county homes left in Ohio, and now they serve the same population that other nursing homes do. Other government-owned homes are veteran homes, which only 2 of these exist in Ohio. When Medicare and Medicaid started paying for nursing home care, then people built nursing homes. Most county homes have nursing care and are certified for Medicaid and Medicare. Here in Region 9, out of our 9 counties, only 4 of them still have county homes. We have the Carroll County Home, the Guernsey County Home, Harrison County Home, and the Holmes County Home. Long-term care acute hospitals are certified like regular hospitals, but focus on patients who, on average, stay more than 25 days. Many of the patients in long-term care acute hospitals are transferred there from an intensive or critical care unit. These facilities specialize in treating patients who may have more than one serious condition, but who may improve with time and care and return back home. They generally give services like respiratory therapy, wounds that need special care, head or trauma treatment, and pain management. As of May 2020, there still were 26 long-term care acute hospitals in the state. Residential care facilities, also known as assisted livings, combine a home-like setting with personal support services for individuals who might not be able to manage at home. Assisted living provides mostly older adults with an alternative to nursing care that can be, but always isn't, both less expensive and less restrictive. Assisted living residents may vary considerably, but most provide meals, housekeeping, laundry, transportation, and social activities. They also offer personal care, such as assistance with eating, bathing, grooming, and some personal hygiene. Some nursing care is also provided, including medication administration and wound changes. There is a wide range of resident profiles in these facilities, some even requiring a nursing home level of care but are living in an assisted living. New assisted living laws allows care that's actually more like a nursing home. Some of them are allowed skilled care on an intermittent basis, like wound changes or special diet management. However, higher standards of staffing and training didn't transfer to the assisted living settings, and as Ombudsman, that's a concern for us as resident advocates. Sometimes assisted livings are attached to or on the same campus as a nursing home. The important thing to know is that each home is unique, and residents should ask what is included in the resident agreement to understand what is provided to them. Unlike nursing homes, there is no control over the growth of these facilities, just what the market can bear. Assisted livings are licensed by ODH, just like nursing homes. They also share the Bill of Rights with nursing homes, which we'll review in the Residents' Rights module. Each assisted living in Ohio receives at least one unannounced inspection or survey every 15 months by ODH, and sometimes less according to a new law in 2021. During these surveys, all aspects of care and services are evaluated based on state laws and rules. The Ohio Department of Health also regulates residential care facilities. Much like a nursing home, residential care facilities, or assisted livings, have an administrator responsible for daily operations. They also employ direct care staff to provide personal care services, and if skilled nursing services are provided, a registered nurse must either be on staff or under contract. For facilities that provide personal care services, at least one staff member must have first aid training. Facilities that administer medication must have a registered nurse, a physician, or a licensed practical nurse who meets state training requirements to administer meds and is being supervised by a registered nurse or a physician. Facilities must also employ or contract with a psychologist or physician if any residents have cognitive impairments with significant ongoing daily living assistance needs, increased emotional needs, or serious mental illness. Residential care facilities were developed out of an interest in having Medicaid pay for non-nursing home settings. Ohio wanted to try it to save money and offer residents more home-like, less medical or institutionalized settings. Now through the assisted living waiver, a resident can get help paying for services in an assisted living through Medicaid if they meet eligibility requirements. Many individuals privately pay to live and receive care in an assisted living. Costs for assisted livings can vary greatly statewide, but generally they range from about $3,000 to $6,000 per month. Ohio's Assisted Living Waiver Program pays the cost of care in a residential care facility for certain people with Medicaid, allowing the resident to use his or her resources to cover room and board expenses. Ohio's area agencies on aging determine eligibility for this program. Continuing with sources of payment for assisted livings, most people in these environments are not receiving substantial medical care or treatment provided by the assisted living. That's how assisted livings differ from nursing homes. Residents can pay for their care at an assisted living a variety of ways, the first being private pay or paying out of pocket. Separate services from room and board, like skilled nursing care, can be billed to Medicare Part B. Medicaid offers the Assisted Living Waiver Program for those who are Medicaid eligible and meet a nursing home level of care. The Assisted Living Waiver helps the resident pay for those room and board expenses. There are a number of assisted livings that do accept the waiver in Ohio, but not all accept it. As of just a couple of years ago, around 2021, there were about 375 assisted livings that participated in the Assisted Living Waiver Program. Some residents have also decided to carry long-term care insurance. Long-term care insurance is coverage that provides nursing home care, home health care, and personal or adult day care for individuals aged 65 or older with a chronic or disabling condition that needs supervision. Long-term care insurance offers more flexibility and options for residents, but it can be pretty expensive. Lastly, MyCare Ohio, which we mentioned just a bit ago, can help residents pay for assisted living care. We'll talk more about MyCare Ohio in a later module. Now we'll talk about residential facilities Class 2. These are also referred to as adult group homes. Many group homes serve those with disabilities, including physical, mental, cognitive, or behavioral health needs. These houses and homes often look like just a regular family home, housing anywhere from 3 to 16 residents. Operators of these homes typically live on site. These facilities are operated and staffed by either an agency or a homeowner. Owners are usually just single owners and not large corporations. Residents in these homes may have a variety of disabilities, including mental illness. These homes might be a good option for people who want to maintain some level of independence and don't require hospitalization or nursing home levels of care, but still may need assistance with daily living, such as meals, housekeeping, and medication management. Operators of these homes cannot administer medications, but they can assist with self-medication, including placing medication on the resident's tongue. Mostly operators are supervisors of residents, observing them to make sure they're safe, reminding them to perform self-care, and keeping important appointments. Staff are required to have a presence 24 hours a day if residents require assistance with bathing, toileting, dressing, eating, medication, and movement. But 24-hour presence of staff is not required in all of these group homes. Sometimes these group homes are locked facilities. In that case, staff would have to be on site 24 hours a day because residents don't have a key. Staff are also required to undergo a background check before being hired. In terms of training, staff must be trained in evacuation and disaster plans, like fire drills, tornadoes, gas leaks, and more. They have to be trained in their basic job responsibilities, in resident rights, and different policies and procedures. They have to be trained in first aid, and they must have continuing education or additional training if residents in the home have mental illness. Residents can pay for care in a group home by paying out of pocket or private pay, but there are also public assistance programs that can help them pay for care. Many residents receive Supplemental Security Income, or SSI, which is a federal income supplement program funded by general tax revenues, not Social Security tax. It's designed to help older people and/or disabled people who have little or no income by providing income to meet basic needs for food, clothing, and shelter. Social Security Disability Insurance, or SSDI, is for people who have become disabled after earning enough Social Security work credits within a certain time. The Residential State Supplement, or RSS, provides financial assistance to adults with disabilities to help with accommodations, supervision, and personal care services in eligible living arrangements, such as group homes. Residents use RSS, which supplements their income to pay the monthly allowable fee or rent to the group home. Some local mental health boards, typically at the county level, called alcohol, drug, and mental health boards, offer programs to help these folks pay for care in a group home. The Ohio Department of Mental Health and Addiction Services licenses and regulates group homes. Licenses must be renewed every 2 years, and operators must undergo a comprehensive on-site inspection of the home during which the Ohio Department of Mental Health and Addiction Services surveyors verify the safe and sanitary condition of the home, the capability of the operator and their staff to meet responsibilities in providing supervision and personal care services. And they also evaluate the appropriateness of placement of each resident in the group home setting. It will be rare that you will assist residents with selecting an appropriate long-term care option for them because you'll be working with residents who already live in long-term care and are hopefully already in an appropriate setting. There might be some residents in the homes you visit that might not be in the best care setting, and you can educate them on other care settings. However, referring them to the staff ombudsman might be a necessary first step. There are other resources they can refer to for help for choosing a long-term care provider. One is the Long-Term Care Consumer Guide. This is an Ohio-specific resource for residents, families, and providers seeking information about Ohio's long-term care providers. Basically, it's just a search engine that allows residents to find the best care setting for them or a loved one. They can find past satisfaction survey results, where Ohio has surveyed residents as well as their families regarding the care received in these facilities. Providers also update the survey guide with the services they prefer. Each long-term care provider in Ohio is required to pay a long-term care resident guide fee annually to pay for maintenance of this site. CareCompare is a national website that functions very similarly to the Long-Term Care Consumer Guide. However, the CareCompare is a federally operated system. It provides survey reports from regulatory bodies like the Ohio Department of Health and gives facilities star ratings based on the quality of services provided, staffing, and past inspection reports. I encourage each of you to visit these web-based resources, try them out, and familiarize yourself with how they work. There's a lot of useful information on these sites, and they might be helpful to you or a loved one as well. Lastly, local area agencies on aging can assist residents in locating an appropriate long-term care setting. For Region 9, our local area agency on aging is in Cambridge, and they cover the 9 counties the same as we do. Next, we're going to go through a few scenarios to help identify and practice what long-term care setting each scenario relates to. Scenario 1. Judy is 89 years old and she's living with late-stage dementia. Because of an accident in her late 70s, Judy is paralyzed from the waist down and uses a wheelchair. She requires assistance with incontinence care, showering, going to the bathroom, eating, grooming, dressing, and taking various medications, including insulin for her diabetes. She has been living in a long-term care setting for the past 11 years. Where do you think Judy lives? So in this case, for scenario 1, Judy would meet nursing home level of care. Based on her assistance with multiple activities of daily living, like going to the bathroom, toileting, showering, eating, grooming, and dressing, as well as assistance with managing her medications, including her insulin, and assistance with mobility. Judy lives in a nursing home. Scenario 2. Leandre is a 54-year-old man living with schizophrenia and a traumatic brain injury that has caused him short-term memory problems. He has trouble remembering when to take his medications and needs assistance with his laundry, grocery shopping, and managing appointments. Since the passing of his parents, Leandre has lived in a long-term care just 2 years. Where do you think Leandre lives? So the answer to this one would be that Leandre lives in an RF2 or an adult group home. This one can be tricky because he does not meet the nursing home level of care, like activities with daily living, but he still needs assistance and some supervision. His mental health diagnosis, though, should give you a clue that he does live in a group home. Now we'll move on to discussing the various departments in a nursing home. Many of these departments also exist in some assisted living facilities, so some of what you'll learn about nursing homes you can apply to assisted livings as well. Here's just a list of the various departments we'll discuss: administration, dietary, activities, medical supervision, therapy, nursing services, social services, maintenance, housekeeping, and laundry. For administration, the administrative unit of a home may include the nursing home administrator, secretary staff, accountant, business office manager, and admissions. The nursing home administrator is required by state licensing law to be in the home to the extent necessary to effectively manage the home and ensure that the needs of residents are being met. This may not be less than 16 hours per week. We can approach administrators to discuss issues if other staff aren't available to assist, or when the issues are about supervisor staff, such as the director of nursing. The dietary department is responsible for planning and preparing the food served in a nursing home in accordance with state licensure regulations and federal certification requirements if it is a certified facility. Some nursing homes have a menu cycle, such as a 4-week cycle or a seasonal cycle. Nursing homes are required to provide nutritious, well-balanced meals and snacks that taste good and meet the dietary needs of each resident. A nourishing snack consisting of a choice of beverages and a food item from a basic food group after the evening meal. Food substitutes of similar nutrition value shall be offered to residents who decline the food served, and serving size may be adjusted accordingly to resident preference. The nursing home shall accommodate a resident's preference or medical need to eat at different times. The dietitian plans menus, regular and special diets, establishes dietary procedures, and is responsible for the content and quality of the food served. This person generally has oversight of all the cooks and the dietary aides. There must be a consulting dietitian and a separate food service manager. A physician must order special diets that must be managed by a dietitian. Examples of these diets include a diabetic diet, a no salt added diet, low fat diet, bland diet, soft diet, puree diet, low protein diet, low residue diet, or a renal diet. Food service personnel are responsible for serving and delivering the food to the residents while it is warm and palatable, whether this is in the dining room or on food carts. They are not responsible to feed the residents, nor are they allowed unless they are trained as nursing assistants or dining assistants. The kitchen is one area of the nursing home where visitation may be restricted due to infection control issues. All nursing homes have an activities program. They must employ a full-time individual and enough assistants to meet residents' activities needs. The activity program should be designed to meet the physical, mental, emotional, and psychosocial well-being and personal interests of each resident. The program schedule should be planned to include daytime, weekend, evening, and community programs to meet the identified need of each of the residents. The activity schedule is generally posted for a week or a month at a time in an area accessible to the residents. As an ombudsman, an observation you may want to make is to see if the activity occurring at the time of your visit is the visit as posted and whether activities are age appropriate. Residents may indicate to you that alternative activities may be desired to meet their individual needs. As an ombudsman volunteer, you should ask residents about activities. Are they individualized? Do they enjoy them? Are they asked what they would like to do? Are their suggestions or requests honored? As an advocate, the words we use matter. Instead of focusing on the calendar of events, see if residents are engaged in pursuits that interest them. One resident might enjoy group activities, while another might enjoy reading books or studying birds. All interests should be accounted for. Each nursing home operator must arrange for a physician to serve as the home pharmacy. It is the medical director's responsibility to monitor the clinical practices of other attending physicians with residents in the home. Some of the other medical professionals you might encounter are an orthopedic doctor. This doctor specializes in the diagnosis and treatment of bones. An ophthalmologist specializes in the treatment of disorders of the eye. And a podiatrist specializes in the diagnosis and treatment of diseases, defects, and injuries of the foot. Therapy and rehabilitation are used to improve mobility, strength, flexibility, coordination, and endurance, as well as to reduce pain. The goals of therapy are to restore, maintain, or promote optimal physical function. Therapists create individualized therapy plans to address each resident's needs. Types of therapy professionals include the following. An occupational therapist is trained and licensed in the state to conduct therapy to restore function to the upper body, such as arms, hands, and neck. A physical therapist is licensed and trained in the state of Ohio to retain or restore functioning in the arms, legs, or feet through movement, exercises, or treatments. And a speech therapist is trained and licensed in the state to restore fine and gross motor functioning to the facial, neck, and throat muscles. Speech therapists also assess and treat swallowing problems. The nursing service section generally includes registered nurses, licensed practical nurses, state-tested nursing assistants, also called STNAs, and certified medication aides. These people provide direct care to the residents. The person in charge of nursing services is the Director of Nursing, or DON. The DON generally has a strong voice in the policies of the home regarding resident care. Staffing levels must be posted for each area of the home and on each shift daily. There must be enough staff to provide an average of 2.5 direct hours of care for each resident in order to meet their needs. Remember that this is an average, not an individual staff to resident ratio. The essential requirement is that there's enough staff to meet all the needs of all the residents. A director of nursing is a nurse, usually an RN, who oversees the nursing department, including nursing supervisors, licensed practical nurses, and nurse aides. The director of nursing writes job descriptions, manages the nursing staff, and writes and executes procedures and policies for nursing practice. Consultation with residents' families, physicians, committees, and community groups are an important aspect of the job. The DON is responsible for quality and safety in the resident care. The DON is required to be present 8 hours per day, 5 days per week, with someone designated to be in charge if they must be absent. A registered nurse has completed a minimum of 2 years of education at an accredited school of nursing. Registered nurses are licensed by the state in which they work, and there are some skilled tasks that only an RN may do, such as administration of IV antibiotics. A licensed practical nurse, or LPN, has completed 1 year in a school of nursing or vocational training school. LPNs are in charge of nursing in the absence of an RN. They often give medications if they have passed special medication courses and perform treatments. They are licensed by the state in which they work. A nursing assistant or aide, most commonly called an STNA, supplies most of the hands-on resident care given in nursing homes. All new nurse aides are required to take, at a minimum, a 75-hour approved training course and pass a competency test. A registry located at the Ohio Department of Health lists the names of those aides who have passed the test. These caregivers are paid a comparatively low wage and they receive few benefits. Their workload is heavy and often physically exhausting. Unfortunately, this heavy workload may limit the amount of time for resident contact and care. This may become impersonal. These factors may also contribute to the frequent turnover of aides in many nursing homes. A certified medication aide, or a CMA, administers certain types of medications, except narcotics, by certain routes. They cannot give injections when delegated by a nurse. The nurse is ultimately responsible for the medications administered by a CMA. CMAs receive 120 hours of training. Few nursing facilities use CMAs. They're more likely to be used by assisted livings. Remember that the nursing home must provide services to meet the individual, physical, mental, and psychosocial well-being needs of each resident. The nursing home must ensure that social services needs related to admission and discharge planning are adequately addressed to ensure a safe and appropriate transfer of a resident to the nursing home or another provider or living arrangement. Social services departments are responsible for identifying the medically related and emotional needs of a resident. If services are not provided in the home, there should be policies and procedures for referrals. This may include accessing the Medicaid system, helping with personal needs allowance funds, contacting family members at the resident's request, and helping the resident with resident council meetings if requested. A social worker is trained to identify medically related social and emotional needs of residents and provide services necessary to meet them. Full-time licensed social workers are not required for homes with fewer than 120 residents, although the provider is required to offer social services. Staff members in maintenance, safety, and sanitation areas are generally responsible for maintaining the repair of the physical plant, equipment, and furnishings in compliance with applicable regulatory codes. They are responsible to ensure that the environment is safe and free from hazards, such as chemicals, biologicals, disinfectants, pesticides, and cleaning supplies. The members of maintenance oversee the physical plant and mechanical operation of the facility. They are also monitoring the temperatures in the environment, such as air and water temperature. Every nursing home has laundry facilities and is responsible for providing clean bed linens and towels and is equipped to launder resident clothing. In the case of Medicaid residents, laundry is a covered service by the Medicaid program. Private pay residents may have to pay for laundry services if they are not included in the basic rate. Many facilities also have policies regarding the marking of clothing with residents' names to help ensure the return to the right person. Each nursing home should have appropriate procedures for the separate laundering of the garments, linens, and towels of any resident who has a communicable infection. They are responsible to return the clothing items to the appropriate resident. Staff providing direct care to residents and working in the laundry room as well should wear protective clothing while in the laundry room. The protective garments should be removed and hands should be thoroughly washed before providing care for a resident. Housekeeping members of the staff are responsible for basic housekeeping, such as sweeping floors, dusting, emptying trash cans, and cleaning furnishings. Because they clean resident rooms, they often get to know residents, and although not officially part of the care team, they have good insight. Now for Section 2, we will transition to learning about the guaranteed rights of residents and the implementation of those rights in long-term care settings. We'll begin by discussing underlying principles of residents' rights. Certain rights are set forth in the United States Constitution for all citizens. Individuals who live in long-term care facilities do not lose these rights when they enter a congregate living environment. In fact, they are guaranteed additional rights under state and federal laws specific to their status as residents. These rights are provided primarily in the following sources: the Federal Nursing Home Reform Law, in federal regulation such as Medicaid and Medicare requirements, and in state laws and rules, both the Ohio Revised Code and the Ohio Administrative Code for nursing homes and residential care facilities. There are two key provisions in the Federal Nursing Home Reform Law that establish the foundation for all of the other provisions. The Reform Law of 1987 was the most sweeping law in history, aimed at person-centered care and quality improvement in nursing homes. Quality of care says a nursing home must provide services and activities to attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident in accordance with a written plan of care. Quality of life says a nursing home must care for its residents in such a manner and in such an environment as will promote maintenance or enhancement of the quality of life of each resident. Residents' rights also have implications for quality of care requirements. Since residents' rights and quality of life are related, what factors do residents consider important for the quality? In 1985, the National Citizens Coalition for Nursing Home Reform asked 450 residents in 15 cities across the country what quality meant to them. Even though that's pretty old, we still share it because over the years, as we have advocated for residents, they continue to tell us through their complaints and conversations with us. They share the following. They define quality as kind treatment by staff, as respect for residents' dignity and being treated like adults, opportunities for choice and input in their care and services, particularly related to food, activities, and personal service, and privacy. Since then, studies continue to support the importance of these same factors to residents. A few central issues were consistently identified. Many of these issues were incorporated as provisions in the nursing home reform law. The residents' rights listed in the federal law, and therefore all of the regulations that follow from them, embody 4 basic themes. If you learn and remember these 4 themes, you'll understand how to work on the specific rights. As regulations differ by the type of provider, these general themes are applicable across provider types. So communication. Ongoing communication between residents, staff, family members, and others is vital and is a protected right through a variety of rights. Choice. Residents have the right to choose and have those choices respected. From a resident perspective, each resident must be allowed to direct patterns of his or her daily life, as well as treatment methods and goals. On the other hand, staff must think creatively and have an attitude of, let's see what we can do. Decision making. Residents must have full information to be able to make informed decisions. And finally, participation. Residents are to participate in their care and treatment, as well as resident groups, activities, whether those are social, religious, or community activities, and the survey process in the administration of. Effective ongoing communication between residents and staff is essential to fulfilling resident rights. A resident might say, "I don't want this food." What does that mean? It could mean that the resident doesn't want to eat a special diet, or it could be the resident's way of saying that the food is unpalatable because it is cold, bland, or it's food that they might have never liked. There might be a different, unrelated problem behind not wanting certain food. When residents exercise their right to say no, staff need to ask questions and observe until they fully understand what the resident is really expressing. Even residents who are not very articulate or have some degree of memory impairment can express their own choices. Specific examples of rights pertinent to communication include resident rights to be fully informed of his or her rights and all rules and regulations governing resident conduct and responsibilities, both orally and in writing, and in a language that the resident understands. They have the right to participate in planning their own care and treatment, and they have the right to voice grievances without discrimination or reprisal, and have prompt efforts by the provider to resolve these. At the end of each slide coming up, there are some questions in red. The question on this slide is phrased as an open-ended question, and this is a good way to get the resident to open up and talk with you, which gives you in turn an opportunity to empower the resident with information. We will use care planning as a good example of how important communication is. Good care planning is vital to a resident's quality of life and care. It's a time when all involved, including the resident's family members, if they're invited, and staff, focus on creating an individualized plan to meet the resident's needs and wishes. A baseline care plan must be done within 48 hours of admission, and the resident should get a summary with a comprehensive plan being completed within 7 days of that assessment. Care plans must be done quarterly thereafter, or any time there is a significant change in status, or when a resident requests a care plan meeting. If a resident does not attend the meeting, the provider must document why. Care plan meetings are great avenues for residents and their families to become more involved in the care. They allow for more effective communication with staff and, if done well, ultimately better care for a resident. Volunteers are likely to hear about care plan meetings and might be invited by residents to participate. It could be a full 21 days before the comprehensive care plan is developed, so the baseline care plan is very important. Note that the question on the end of this slide is a closed-ended question, sparking a yes or no answer. If the resident answers no, that's your opportunity to give them information about their rights and encourage them to participate. If the resident answers yes to this question, that's your opportunity to ask how they're run, whether the resident feels heard, and whether their care reflects what is in the plan. Every resident has the right to exercise choice, make decisions about their lives, and have those choices respected. A primary example is the right to reside and receive services with reasonable accommodation of individual needs and preferences. From the resident's perspective, this right means that the provider and staff must allow each resident to direct the patterns of his or her daily life, as well as treatment methods and goals. From the staff's perspective, resident choice means that the staff needs to think creatively to see life from the resident's viewpoint when a request is made or a preference is stated. Instead of saying no, or we can't do that because, the staff should say, let's see what we can do. An individual's choice and preferences may change after a person has been in the home a while, or if their condition changes, they might make different choices than ones previously stated. Exercising choice is a continual process. Every resident has the ability to exercise his or her own rights unless that individual has been deemed incompetent according to state laws. To exercise decision-making, residents need full information to be able to make a truly informed decision. They need accurate information about alternatives and consequences, both short and long-term, of the decisions they're considering. Decision-making is the implementation of exercising choice. One of the requirements of the nursing home reform law is that nursing homes must protect and promote the rights of each resident. Note the word each. You might hear staff say that in their practices are in the best interest of residents. It's an opportunity to remind them that they should treat each resident individually. A few specific examples of rights in this area are a resident's right to manage his or her own financial affairs, to work or not work, and the right to choose a personal attending physician. Residents are to participate in planning their care and treatment, and to participate in resident groups if they so choose, social, religious, and community activities, the survey process, and the administration of the home. Even residents with a diagnosis of dementia can participate in planning care and exercising choice. If a resident's preference cannot be honored, the staff need to engage in the problem by helping them find a solution that is as close as possible to what the resident wants. Residents need to be familiar with the grievance process and have confidence that the process will work. Facilities are required to assure resident and advocate participation in the administration of the home. These four themes that we talked about, communication, choice, decision-making, and participation, embody the approach, attitude, and philosophy of implementing resident rights. They have to be continuously exhibited. As an ombudsman, you may be the best model and teacher for implementing resident rights. Ombudsmen can play an important role in helping people restore their own sense of themselves and regain their sense of personal power and voice. Residents who have always felt it easy to speak up may merely need to be pointed in the right direction and be given a little assurance that they're within their rights. Others may need a lot more encouragement. They may need you to go for them or with them. If people are sick, immobile, or alone, you may have to carry more of the load for them. They may have limits on what they want to take on for themselves. They may want to address their problems, but will need you to work with their condition. The first step in this process of empowering residents is simply to have genuine, meaningful connection with residents, to get to know them as individuals. Real human connection can be immensely restorative. In the course of that connection, residents may share concerns about their day-to-day experience. How ombudsmen respond and work with these concerns can go a long way in empowering residents and restoring their sense of self. It is important throughout such a process to relate honestly and authentically to the resident and to the situation. We'll talk about the ombudsman role and give examples of ombudsman activities throughout this module. Now we're going to review some rights that you might hear about more specifically. Here are some rights specific to information, including provider charges and services, including a notice given 30 days in advance when there has been a change in status. Changes in policy, which, by the way, cannot supersede rights. Ohio Department of Health survey participation and results. Residents have the right to access the Ombudsman program. Facilities must post contact information for the Ombudsman and other agencies. We do provide them posters, and facilities must allow Ombudsman access unescorted during reasonable hours and provide a private space to meet with residents. Residents have the right to know about their personal needs allowance and how much money they maintain in it. The resident might ask the home to manage the account, but it's not required. And they also have the right to information about Medicare and Medicaid coverage and non-coverage. Here are some rights about quality care and treatment. Residents have the right to a safe and clean environment. They have the right to choose a physician and have access to specialists. They have the right to have the provider send notification to the family, significant others, if they experience a change in condition. Such notification is required within 12 hours. Families should never be in the dark, but keep in mind that some residents might not want their family notified, or might want one daughter but not the other informed. And residents also have the right to be free from discrimination of all kinds. The Ohio Resident Bill of Rights includes a definition of a sponsor. A sponsor is an adult relative, friend, or guardian of a resident who has an interest or responsibility in the resident's welfare. You will hear about family, legal rep, responsible party, and other terms, and most of them fit the definition of sponsor, but sometimes using the right terminology will be important, and we can always help you with that. Next, we're going to talk about privacy rights. Residents have the right to correspondences in private, whether that's mail or phone. They have the right to not have their mail opened by staff or others. And how a facility handles their phones might differ. Maybe they might have a cordless handset that they take to the room. Maybe the residents have individual phones in their room. Sometimes they might have phones in the hallway, but that can be a problem because that's interfering with the right of privacy. They have the right to have visitors of their choice in private. Sometimes there might be issues with visitors, and a facility might try to supervise a visit or deny a visit, but the Bill of Rights allows for that in very limited circumstances. Such examples should be reported to us here at the Ombudsman Program. They have the right to share a room with a spouse. They have the right to keep their door closed. Staff should knock first and then wait for an answer before proceeding in. They have the right to receive medical care in private. Staff should not administer medication in the dining room, check vital signs, or other care in front of residents. If a resident has a question, they might hesitate to ask in front of other residents. They have the right to confidential financial and medical records. Anyone accessing records must have permission from the resident or a sponsor with appropriate legal authority. Here are the rights about dignity and respect. This is one of our top complaints statewide year after year. Residents have the right to be free from physical, emotional, mental, and verbal abuse. Technology, while it's usually a good thing, can be misused, and people have been convicted of abuse for posting videos on social media. sharing videos of Snapchat of residents being taunted. Residents have the right to reasonable requests properly responded to. They have the right to be called by their preferred or given name. They have the right to retain and use possessions and clothing in a secure manner. Sometimes facilities will have an admission agreement that states they are not responsible for lost or stolen belongings, but the Bill of Rights in Ohio does not allow waiver rights in this way. Residents have the right to unrestricted access to property. The business office should have reasonable hours for residents to get their money. We have seen facilities limit residents to $5 a day, and the office is only open for an hour a day. That is not reasonable, and access should also be individualized. For example, if a resident goes to church every Sunday and wants cash for the collection plate, the resident must be able to get to their money to do that. Residents maintain all of the civil rights that they possessed prior to living in a long-term care setting. Here are just a few. They have the right to vote. It might surprise you to know that even if a person has been determined to be incompetent by a court, unless the judge explicitly denies them the right to vote, they still get to vote. The County Board of Elections have the ability to assist residents with voting by going to the home. You'll receive more information about this around election time. They have the right to marry and divorce. They have the right to move out of the home, even if it is against medical advice. The provider still has an obligation to help with a discharge plan to make it as safe as possible. They have the right to choose not to accept medical treatment. This is not an all or nothing thing. On a given day, residents with diabetes might want to eat a piece of pie. That doesn't mean they want the home to forego their normal diabetic diet. Each time a resident makes a choice that is contrary to a physician order or care plan, the home should explain the consequences of the decision but respect the resident's choice. Residents also have the right to smoke or drink alcohol per the facility's policy at admission. Taking away a resident's right to smoke or drink should be based on a medical reason documented by the physician. Even then, the resident may make another choice. If serious enough conditions, like smoking in their room against policy of the home and state and federal rules, the home will likely issue a discharge notice, and the ombudsman will work with the resident on solutions if requested by the resident. Residents have the right to protections around transfers and discharges from the home. They must be provided a 30-day written notice for discharge that includes the reason for the discharge, the proposed location, the right to an impartial hearing, the right to remain at the facility until the proposed date, and the address and phone of a legal service office, ODH, Ohio Legal Rights, and the Ombudsman Program. Allowed reasons for discharge include if the resident's health improves, non-payment, if the safety of other residents is endangered, or if the provider cannot meet the resident's needs. Notices don't always have to be given with 30 days, but most should. It's important to know that as Ombudsman, we can help with discharge hearings. If you run into issues about transfer or discharge, just ask us and we can see if we should get involved. Finally, residents have the right to a reasonable notice for any proposed room change, and the change cannot be due to staff convenience. The provider has some additional responsibilities when it comes to discharge from the home. It must inform the resident of the bed hold policy for therapeutic leaves and hospitalizations. It must also provide appropriate discharge planning, which should start as soon as the resident moves in. Finally, it must provide adequate preparation prior to discharge to ensure a safe and orderly discharge. Residents should obtain the medications and equipment needed to go home safely, as well as have a plan for home care services to be in place shortly after discharge. Here are some additional rights you should know about. Residents have the right to change clothes and have bed linens changed as needed. They have the right to receive their monthly bill and itemization at least quarterly. They have the right to remain free from financial exploitation, and they have the right to voice concerns or grievances without reprisal or retaliation. Switching gears now, we're going to talk about resident rights related to restraint. I'm going to say the right in full about restraints. So, the right to be free from physical or chemical restraints or prolonged isolation, except to the minimum extent necessary to protect the resident from injury to self, others, or to property, and except as authorized in writing by the attending physician for a specific and limited period of time and documented in the resident's medical record. Prior to authorizing the use of a physical or chemical restraint on any resident, the attending physician shall make a personal examination of the resident and an individualized determination of the need to use the restraint on that resident. Physical or chemical restraints or isolation may be used in an emergency situation without authorization of the attending physician only to protect the resident from injury to self or others. Use of the physical or chemical restraints or isolation shall not be continued for more than 12 hours after the onset of the emergency without personal examination and authorization by the attending physician. The attending physician or staff physician may authorize continued use of physical or chemical restraints for a period not to exceed 30 days, and at the end of this period and any subsequent period may extend the authorization for an additional period of not more than 30 days. The use of physical or chemical restraints shall not be continued without a personal examination of the resident and the written authorization of the attending physician, stating the reasons for continuing the restraint. If physical or chemical restraints are used under this division, the home shall ensure that the resident restrained receives a proper diet. In no event shall physical or chemical restraints or isolation be used for punishment, incentive, or convenience. You might be wondering, are restraints ever appropriate? Well, yes, but the decision to restrain must always be based on the individual level of needs of the resident and addressed in the resident's plan of care. Restraints should only be used after all safer and less restrictive alternatives have been eliminated. And remember, a restraint can only be ordered by a physician after he or she is seen in person by that doctor and must be reevaluated every 30 days. Finally, restraints may never be used as punishment, incentive, or for the provider's convenience. Restraints have the effect of restricting freedom of movement or normal access to one's body. Here are some common examples of physical restraints, but keep in mind whether they're really restraints depends on how they are used. One example is a vest. Vests may be used to tie the person to a bed or a chair. These are not permitted in nursing homes. There may be wrist or waist restraints, mitts. Jerry chairs and Broda chairs can even be examples of physical restraints. Lap buddies, side rails on beds, Mary walkers, sheets tucked too tight, alarms, and sometimes catheters are unfortunately used as a physical restraint. Ohio has a very low rate of reported physical restraint use in nursing homes. They aren't allowed at all in other settings. This is 0.1%. Some of the examples might be restraining residents, but aren't reported as restraints. However, 14% of Ohio nursing home residents take antipsychotic medications, which can be used to chemically restrain someone. Side rails on beds come up in calls to us here at the Ombudsman Office often. Under Ohio law, if the resident is not able to lower the side rail and there's not a medical reason to have it, side rails can be considered a restraint. There are mixed opinions about side rails, but just know that they can be dangerous, and there are alternatives to keep someone safe. Talk to the staff ombudsman if you notice this issue in a home. Medications can be used as a type of restraint. Here are some common examples: the use of antipsychotics or tranquilizers, sedatives or hypnotics, antidepressants, anti-anxiety drugs, or antihistamines. Antipsychotic medications have a black box warning against use for someone living with dementia. There has been a national effort for several years to reduce the use of these medications. In Ohio, we dropped from about 25% to about 14%, and we're now 25th in the country. There are so many risks associated with the use of restraints. We'll review some of them now so that you have an idea of why it's important to ombudsmen to advocate for their elimination. Incontinence, if the resident is not taken to the bathroom. Urinary retention. Many psychoactive drugs affect the ability to release urine. UTIs. These are caused from urinary retention and incontinence, a lack of fluids, and not moving. Pressure ulcers, if a resident is in one position for too long. Dehydration, if a restrained resident is unable to get up to get anything to drink. Bruising or skin tears, if the restraint is applied incorrectly, if the resident is struggling against the restraint. Contractures, they might have prolonged inactivity, and this could cause loss of muscles and bone. Depression and lethargy. Resident gives up when they're restrained. They might have a broken spirit. They might panic or have anxiety or increased confusion. They might be frightened by the constraint. Constipation, a lack of activity and inability to get enough fluids if they're not taken to the bathroom according to their bowel pattern. Brittle bones and fractures. Prolonged inactivity can cause loss of bone mass. A decreased appetite or malnutrition. Inactivity decreases the appetite, and restrained residents are unable to eat by themselves. Sometimes residents who are restrained are even too depressed to eat. They might get swollen hands and feet from remaining in one position for too long, or pneumonia from inactivity. They might become agitated or frightened by the restraint. Sometimes drugs intended to calm a resident, has the reverse effect. They might have repetitive movements. Some chemical restraints might cause a resident to have repetitive movements of their head or their tongue or their feet or their arms. Physical restraints also pose the risk of death due to compression of the chest or strangulation. Now that we know why restraints are so harmful, what are some of the alternatives to help keep people safe? So alternative positioning aids, such as pillows, positioning cushions and wedges, deep-seated chairs, anti-tip chairs, or anti-slip surfaces. Another alternative is a lower bed, or maybe a wider bed, or thin mattresses. It could be bed placement. The bed might be pushed against one wall so that the resident can see outside. Bean bags, rocking chairs, lower chairs, or even GATE training and physical therapy. Exercise classes or physical therapy. Another alternative to restraints might be TV, video, music, games, or picture books. These include individualized activities or repetitive non-thinking tasks, such as sorting coupons, sorting coins, looking at pictures, or sorting through mail. Another alternative to restraint is actually toileting according to the individual's schedule and assessing their comfort or pain relief. Massage or therapeutic touch is another great alternative to restraints. Food and hydration, non-skid shoes, sensory communication aids. What does the resident like to see? What do they like to hear, touch, taste, or smell? They might have a book or a light sweater on their lap. So here we're going to dive into some ways that Ombudsman can encourage residents to exercise their rights. We can help residents, families, and staff understand what these rights mean in everyday life. We should be alert for opportunities to suggest that residents can exercise choice and have those choices respected. Be alert for opportunities to do this while educating staff on how to do it, that it doesn't cost more and the benefits are endless. You should also encourage residents to express their preferences. Be aware that they may have a fear of retaliation, a fear that staff will treat them differently because they have done so. Staff are not allowed to do this, and you should let the resident know that if they express the concern. Residents should not settle. Wherever they live is their home. The mindset should be that staff work in the resident's home, not that the residents live in the staff workplace. Encourage and participate in brainstorming with staff and residents about ways to accommodate individual needs and preferences. Share ideas and approaches that have worked in other situations. Often it's not that staff don't want to accommodate a need or preference, but that they don't know how. Ombudsman can be really valuable to staff in that they see things in what work in other homes and can bring that to problems elsewhere. Use care planning as a problem-solving vehicle to focus everyone's attention on the resident's needs, routines, and preferences. These are also good discussion points for resident council or family council meetings. We want to focus on strengths, abilities, and resident independence as much as we focus on their needs. We want to encourage residents to attend care plan meetings. Remind them that they can schedule them anytime. They don't have to wait for the quarterly required meeting. Also, they must be known that they can invite whoever they want to participate in their care plan meeting. We can help staff to think, how can we? No one is going to admit that they don't want to respect resident rights. We need to capitalize on that and focus on operationalizing their stated desire. We're all here for the same reason. There are some obstacles to residents exercising rights. Let's run through some of them. Although this list was developed with nursing home residents in mind, the concepts are applicable to anyone who is dependent on others for long-term services and supports. Residents might be intimidated by the idea of appearing to criticize the provider of services. Some residents don't want to seem like a complainer, so they just go with it. They may not know that they have specialized rights and do not know what their rights are. Most people are unaware that they have rights in law and rules that facility must follow. This is why we rely on our volunteers for advocacy visits, so that they can spread the word to new residents. Residents may not think about their problems and concerns in any context related to their rights. Some residents just have no idea that their problems may be in violation of their rights. For some, there are many opportunities to exercise control over their lives or to have intellectual discussions. Some residents are used to decisions being made for them and haven't had much of an opportunity to speak up about the things they want. Informing them they have a choice is a highlight to doing ombudsman work. You'll see what I mean once you get out there and start doing visits. Residents are usually surprised but very happy to hear about this. Some residents don't have many relationships in which to practice interactive or assertiveness skills or negotiate their rights. Residents, like all of us, their battles and often put up with daily violations of their individuality and dignity. They don't want to ruffle any feathers since they heavily rely on staff for care. Some think an occasional meal will be fine if that's all they have to worry about. For residents, autonomy is undermined from the start. Most would rather not be in a nursing home or have strangers come into their home. Many did not have much of a role or choice in the decisions about care and may feel there are no other options. Just like I mentioned on the previous slide, some are used to decisions being made for them on a regular basis. Some residents may have low expectations. Encourage them to expect excellence in their care. This is their home and their life. They have a say in their care and how they're treated. There can be a tension between desire for independence and need for assistance. Many feel more comfortable championing another's problem than asking for help themselves. How many of us are better at giving advice and helping others, but when it comes to our own lives, we tend to not be able to help ourselves get through certain situations. We've all been there, right? It's always easier to deal with other people's problems and push ours to the side, or suddenly seem confused on what to do. If you run into this, that's okay. We're still able to get the information that we need that there is a problem. Sometimes you can get this information from resident council presidents or other concerned residents on behalf of their fellow residents. Finally, the physical, emotional, psychological, social, and mental disabilities that some residents are living with make it difficult to voice their concerns. Just because there are disabilities among residents doesn't make their rights less meaningful. Our job is to advocate for everyone. In a future module, you'll learn how to adapt your advocacy as needed. It's not a cookie-cutter approach. Moving on to Section 3, Person-Centered Care. Now that we've learned about residents' guaranteed rights, let's transition over to person-centered care, or how providers should approach resident care. Person-centered care means treating residents as individuals and as equal partners in their care. It is personalized, coordinated, and empowering. Person-centered care is multidisciplinary, recognizing that a person may need more than one professional to support them with a person-centered approach. These are the key values associated with person-centered care. Choice and self-determination. This means that every person has the ability to express preferences and to make choices. Each person is the primary authority on his or her life. Dignity and respect. This means that a person's choices and preferences shall always be considered. Purposeful living and a supportive environment. This means that every person has strengths, gifts, and contributions to offer. Every person has hopes, dreams, and desires. Really good person-centered care means that all staff can and will serve residents in this way, no matter what they need. As Ombudsman, we will always advocate for a person-centered approach to care. These are our values, and we should model them and educate providers about them in an effort to improve care quality in long-term care settings. A nursing home is a place residents call home, a place where someone lives and calls home should nurture the human spirit as well as meet medical needs. Person-centered care focuses on the resident and supports them in making choices and having control of their daily life. Person-centered care is an important component in residents' rights to care and services to attain or maintain the highest practicable physical, mental, and psychosocial well-being, as promised in the Federal Nursing Home Regulations. The goal of person-centered care is to de-institutionalize the long-term care setting to create an environment that follows the residents' routines rather than those imposed by staff and provides truly individualized care. It is the role of the Ombudsman Program to advocate for residents and their right to make choices to direct their care in life and in long-term care facilities. So modeling person-centered care is also about the words that we use. We must be intentional when we talk about residents. We need to think and talk about the person, not their diagnosis, not their disability. Doing this is easier said than done, especially when we might use a different language in our personal lives. As ombudsmen, we need to prioritize using humanizing and age-positive language in our advocacy, because how can we expect providers to do this when we don't? Here are just some examples of what not to say and what to say instead. What to say instead. I just want to highlight some of the common ones. Instead of calling someone a diabetic, we could say a person who has diabetes. Or instead of considering a resident as a Hoyer lift, we could say a person who requires a lift to get out of bed. Instead of saying a diaper, we could say a brief. A resident is not a dementia patient, but a person living with dementia. There may be people who need assistance with eating, but they shouldn't be referred to as feeds. Residents should not be referred to by their ailments or their room numbers. They should be referred to by their names. Even in our ombudsman world, we are always making changes and making sure that our OTIS instructions and guidance are person-centered. So we're going to go through a couple scenarios to help us practice person-centered language. There are 3 scenarios in total coming up. So scenario 1, you overhear the charge nurse in your assigned home say to an aide, there are 3 new admits today, room number 34, 38, and 42. 2 of them are 2-person transfers, so you need to pull in Jennifer to help you. How could we rephrase this statement to make it more person-centered? So we could rephrase this by saying something like, we have 3 new residents moving in today. Jerry will be living in room 34, Edna will be living in room 38, and Alejandro will be living in room 42. Jerry and Edna both require 2 aides to help them get into their wheelchairs. Jennifer is aware and can help you. Moving on to scenario 2. You approach an aide and ask her how many residents are living in the memory care unit. She replies, we have 10 dementia patients right now. How could we rephrase this sentence to make it more person-centered? So we could rephrase this sentence by saying, or the aide could rephrase this sentence by saying, we have 10 people living with dementia in the memory unit. Moving on to scenario 3. You see 2 aides walking towards you down the hallway. One is pushing a meal cart and the other is chatting. You overhear the aide say, I have 4 feeders on my wing. Ugh, it's going to take me forever. How can we rephrase this sentence to make it more person-centered? So the aide could rephrase this by saying, there are 4 people who I need to help with eating today. Could you help me? I think it might take a while to make sure they get enough to eat. The word feeders is jargon, so people might not necessarily understand this phrase, and that's okay. This should just convince us that our words matter. So the next couple slides, we know that environment is important and can give us some indicators in long-term care about the home's efforts toward culture change. There will be a series of pictures, and I just want you to kind of take mental note about what you notice of each of the pictures. Which of them look like home and less institutional? And where would you rather be? So here's example 1. Where would you prefer to live or sleep? Which picture looks like home? What looks less institutional? What gives you that impression? And where would you rather be? Which of these rooms would you rather be in, and why? What bathroom would you prefer to use? What looks less like home? What looks more institutional? And what gives you that impression? Which bathroom would you rather use? And finally, where would you prefer to dine? Which one looks like home? Is there one picture that looks more institutionalized than the other? And what dining room would you rather eat in, and why? Person-centered care can overhaul the culture of a long-term care setting, but these simple changes can start the process. Having consistently assigned staff that know a resident's preferences is important for consistency and relationship building. Providers should involve families in care conferences, activities, and decisions about their loved one. Creating an environment that is as home-like as possible, personalized, warm, and inviting can make a huge difference for someone's quality of life. This can involve carpet instead of tiled hospital-like floors, various houseplants, comfy furniture, color, the inclusion of pets, snacks made available at all times, and personalized living spaces. Anything to make the resident feel like the home is their home and not a hospital or not an institution. Spontaneous activities are also important. Most of the activities that we decide to participate in are not planned. For example, a spontaneous trip to the park or a local farmer's market. Purposeful living can mean a variety of things to different individuals, but it is important to make residents feel like they're making an impact. Utilizing resident skills and expertise to help improve things is a start. Maybe Marjorie loves to garden. Perhaps she can spend some time weeding in the courtyard and planting fresh flowers each spring. Alan used to paint murals. Perhaps he can paint one on the home's activity room walls. Justin was an editor for various publications throughout his career. Perhaps he can write a resident-focused newsletter. We're going to talk about care planning in the next section. However, care plans should involve the resident and be written from the perspective of the resident, but they often do not and are not. Now we're going to switch gears and move on to section 4 and talk about comprehensive assessment, care planning, transfers, and discharges. When a resident enters a nursing home, it is the provider's responsibility to assess the person to determine their care needs. While nursing homes are required to perform this assessment, other long-term care settings use something similar to determine a resident's needs and preferences. The purpose of a comprehensive assessment is to find out who the resident is and incorporate his or her needs, interests, and lifestyle choices into the delivery of their care. The resident is an individual with strengths, as well as functional limitations and health problems, and these must all be explored in this initial assessment. This assessment is then used to identify possible causes for each problem area and guidance for further assessment and resolution or intervention. The assessment begins with the Resident Assessment Instrument, which is a large document that consists of 3 basic components: the MDS 3.0, Care Area Assessment, and RAI Utilization Guidelines. The MDS, or Minimum Data Set, is a core set of screening, clinical, and functional status elements, which forms the foundation of a comprehensive assessment. It is completed within 14 days of admission, anytime there is a major change in condition, and on a yearly basis. The Care Area Assessment, or CAA, process is designed to assist the assessor to systematically interpret information recorded on the MDS. There are care area triggers, or CATs, to determine in what areas the resident is at risk and the need for more assessment, the CAA and the CAA summary. Care areas are triggered by MDS item responses that reflect conditions, symptoms, and areas of concern, and indicate the need for more in-depth evaluation. The key to successfully using the RAI process is to understand that its structure is designed to enhance resident care, increase a resident's active participation in care, and promote quality of life. A care plan is a roadmap to residents' care. Residents should be involved in and have control over the care planning process. Care plans should be written in the resident's voice, from the resident's point of view, and be individualized to the resident. Residents have the explicit right to identify individuals' roles to be included in the planning process. They have the right to participate in establishing goals and outcomes of care, and the type, amount, and frequency, as well as duration of care. They have the right to request care plan meetings. They have the right to request revisions to the person-centered care plan. They have the right to receive the services and items in the plan of care. They have the right to see their own care plan and sign after significant changes are made to the care plan. Care plans should be specific and individualized. They should be written in common language that everybody can understand. They should have the resident's agreement and be supportive of residents' well-being, functioning, and resident rights. Care plans should also utilize a team approach based on problems identified in the assessment, meaning all departments of the home are aware and are following the care plan. And care plans should also be reevaluated and revised routinely. In addition to supporting resident participation in the care planning process, Ombudsman can use care planning as a tool in advocacy as part of the problem-solving process. Staff ombudsmen are responsible for working with the resident and the provider to determine if a care plan meeting is in order. But as a volunteer ombudsman, you can educate the resident about care plans and empower residents and their loved ones to request care plan meetings. Care plan meetings may be helpful when residents and families need information, when residents and families have concerns about the delivery of services, when a provider is acting in a way that does not comply with federal and state standards, when a provider's complaint resolution process has failed, when a resident receives a discharge notice, and when the ombudsman wants to bring several people together, each of whom has a role in the resident's care. A resident has the right to choose who participates in a care plan meeting, but when a resident does not have the capacity to make such decisions, the ombudsman will work with appropriate resident representatives and loved ones. Direct care staff are required to participate in these meetings as well. So not only must the provider plan for a resident's care when they enter the home, they need to plan for when the resident exits the home as well. This process is either known as a transfer or as a discharge. A transfer occurs when a resident moves from a provider to another provider with the expectation that they'll return. The most common example we see here is when a resident goes to a hospital temporarily to receive some more care. While they're gone, their bed is on hold, so it's still there for them when they return. A discharge occurs when a resident moves from a provider without the expectation of returning. This could mean they're transferring to a different long-term care setting, or they might be going back to live in the community. People do use these terms interchangeably, but it's important to use the right one because it's indicative of the expectation that the resident may return to the home. So discharge planning actually starts at admission. There's a section in the MDS that discusses the resident's desire to return to the community. Just like any other area of the assessment and care plan, discharge planning is an ongoing, constant process while the resident is in the facility and should take place for each and every resident. Residents should be encouraged, but not forced, to engage in their discharge planning. At the very least, the provider should be making sure that the resident is comfortable with the discharge plan and that it aligns with the resident's goals. In most cases, residents want to be involved with their discharge planning. Regarding intent, if a provider has a discharge plan in place to address the resident's discharge goals and needs, this includes caregiver support. It includes referrals to local agencies. It includes involving resident and/or their representatives and involving interdisciplinary teams. Discharge notices have certain requirements under the law. The resident must be given a notice in writing 30 days prior to discharge, meaning that this discharge notice has to be dated. The reason for discharge must clearly be stated on the discharge notice. There are a few different reasons that are lawful reasons to discharge a resident, and the reason must be worded in a certain way to be acceptable. For example, the exact language to be used when a resident has not paid and cannot pay for services must be that the resident has failed after reasonable and appropriate notice to pay or have paid under Medicaid and Medicare for his or her stay at the facility. This information comes from that federal law, the 42 CFR. Discharges are also required to propose a location of discharge. Discharge to a hospital is not acceptable. Discharge to a homeless shelter, unfortunately, is lawful, although staff will advocate against this. When thinking about the discharge location, ombudsmen often scope out the location to see if it meets care needs. If it doesn't, then staff will most likely suggest that the resident request a discharge hearing. In the case of a location being another long-term care provider, the proposed location for relocation need not have accepted the resident at the time the notice is issued. The discharges need to include contact information for organizations that can assist the resident. The Ombudsman, the Ohio Department of Health, and sometimes Disability Rights Ohio are included on discharge notices. The resident has the right to appeal a discharge. They have until 10 days before the discharge date to request a hearing. Hearings are facilitated by the Ohio Department of Health and include a contracted attorney known as a hearing officer. The hearing officer will hear the side of the resident and they will hear the side of the provider and then make a ruling. The staff ombudsmen are often involved in these discharge hearings, but only at the request of the resident. Hearings are not held in a courtroom or any formal location. And during the COVID pandemic, hearings were held virtually or over the phone. Now, there are some scenarios that do not require 30 days notice, and these reasons can include that the resident's health has improved sufficiently that they no longer need skilled services, that there's an emergency, that safety of the residents is endangered, or an emergency in which health of the residents is endangered, or if the welfare and needs cannot be met in a facility. Sometimes these notices are called emergency discharge notices. These are the lawful reasons that a resident may be given a 30-day discharge notice by a provider. That the resident's health has improved sufficiently that they no longer need nursing services, that welfare and needs cannot be met in the home, that they have failed after reasonable and appropriate notice to pay for their stay at the facility, that the safety of individuals in the home is endangered, that the health of individuals in the home is endangered, or if the facility needs to close and they cease to operate. Typically, the goal of the Ombudsman is going to be to prevent discharge, and this is assuming that the resident's goal is not to leave the home. Of course, we will honor the resident's goals and use a person-centered approach to handling discharge. Staff ombudsman would work to honor that goal without having to hold a discharge hearing. So, in this case, they would speak with the provider, try to identify any solutions that might be available. For example, the resident can't afford care, so the provider gives them a discharge notice. A solution the ombudsman would look into is if the resident is eligible for Medicare or Medicaid. Then we would ask the facility to assist the resident in applying for those benefits in order to pay for care. And of course, we would also help the resident with this process. Avoiding discharge also prevents something called transfer trauma. I'm sure we can all agree that moving is stressful, and even in the best of circumstances, it's very stressful. But moving to an unfamiliar place filled with unfamiliar people can result in a lot of stress. Discharge, when it is not the resident's choice, can be frightening. It can cause a fear of being homeless or simply a fear of the unknown. As ombudsman, we need to understand that a long-term care provider is the resident's home first. It is not a business that the resident just happens to live in. Even discharge hearings can cause trauma because they can be adversarial and intense. It can cause emotional distress in the resident, which is one reason why we want to try to avoid them. Discharge does not have to be adversarial or intense. Working with a provider to identify and solve the underlying problem can help educate the provider on their responsibilities around discharge planning. It can also help educate the resident on their rights around transfer and discharge. As an ombudsman volunteer, we rely on you to educate residents on their rights during your regular advocacy and empower them to self-advocacy. So while staff ombudsmen are going to be the ones dealing with discharge notices and appeals, you can help mitigate that from ever happening by empowering the resident with the information they need to stop a discharge from occurring. We're going to wrap up this module in the final section by discussing resident and family councils. Residents have a right to voice grievances without discrimination or reprisal and have prompt efforts by the provider to resolve these. They also have the right to recommend changes in policies. One of the ways they can do this is by participating in the grievance committee. Administrators must establish a grievance committee for review of complaints by residents. The grievance committee shall be comprised of the nursing home staff and residents, sponsors, or outside representatives in a ratio of not more than 1 staff member to every 2 residents, sponsors, or outside reps. Residents have the right to participate in decisions affecting their lives. All nursing homes must allow the formation of resident councils, give space, and provide feedback about concerns raised. Attending a resident council meeting is a great way to learn about what's happening in the home. Lots of volunteers do attend these meetings. An invitation from the resident council member is necessary to attend. Don't be shy. Feel free to request an invitation. And we can do more than just listen. We can tell residents about their rights, and we can say that ombudsmen can help address any complaints they might have. Let them know how often you're in their building and that you look forward to getting to know everyone. Also add that they can reach out to the Ombudsman program at any time. One of the federal requirements of the Ombudsman is to assist with resident and family counsel. So what is a resident council? A resident council is an organization whose purpose is to provide residents living in long-term care setting a form of self-government. What do resident councils do? They give residents the opportunity to voice concerns about the quality of care, quality of life in the home, and to influence changes in rules, policies, and practices. What are some of the benefits of a resident council? Well, for residents, it can promote independence and opportunities for personal growth. It can provide opportunities to express talents and wisdom. It can provide a forum for healthy self-expression and maintain a quality environment for healthy living. For staff, it can provide information about concerns. It can provide creative solutions to problems. It can provide recommendations for programs or policies that would benefit residents. And it can also provide a forum for constructive exchange of information. For both residents and facilities, resident councils can provide open lines of communication between residents and staff. They can encourage a good working relationship between residents and staff. They can help solve problems before they become major issues. They can improve resident satisfaction and make a difference in the life of residents in the home. A resident of a long-term care provider has the right to participate in decisions that affect the resident's life. The provider must listen to the views and act upon grievances and recommendations of residents concerning proposed policy and operational decisions affecting resident care and life in the home. Families have the right to meet in the home with other families and form family councils. Providers must listen and act upon their views and concerns and must give space to meet. Unfortunately, there are very few family councils active in Ohio. If you ever hear of a family member that might be interested in establishing one, let us know. We can help them. So what is a family council? A family council is a self-led, self-determining group of residents, families, and friends of nursing home residents that work to improve the quality of care and quality of life for the residents. What do family councils do? A family council acts upon concerns and complaints affecting nursing homes. Residents, supports families, communicates with nursing home administration, advocates for positive change, and educates families about issues relating to residents. What are some of the benefits of a family council? For family members, family councils can provide support, encouragement, and information. They can provide an avenue to constructively channel concerns. They can reduce the sense of isolation, helplessness, and frustration. They can give a greater sense of control. They can improve the care of their loved ones. For staff, family councils can provide information about concerns. They can provide creative solutions to problems, provide recommendations for programs or policies that would benefit residents. Family councils can give the home an opportunity to fix problems and give honest feedback for improving quality of care for residents. For both families and facilities, family councils can promote open lines of communication. They can build trusting relationships and create a sense of community. Family councils can also provide opportunities to make improvements for all residents and improve the quality of life and quality of care. So the 1987 Nursing Home Reform Law guarantees nursing home residents and their families important rights that enhance the nursing home experience through resident and family groups. This is supported in Ohio law as well, and we'll talk about that in just a moment. According to Section 483.10 F5, residents and family members have the right to hold private meetings as a group, known as family or resident council. Federal law references families of residents may participate in a family council, but this can also include sponsors such as close friends of residents. Take a second here to just read the rights of resident and family councils here on the screen. Moving on, federal regulations do not apply to Ohio's residential care facilities or nursing homes that are not certified. Examples, ones that do not accept Medicare and Medicaid. There are very few nursing homes in Ohio that are not certified. However, this is also applicable in non-certified nursing homes and residential care facilities that have resident or family councils, or for residents of those facilities and their family members who wish to organize them. The Ohio Resident Bill of Rights provides rights and protections for residents of all of Ohio's nursing homes and residential care facilities. The most pertinent right afforded nursing home and residential care facility residents and their family members states that residents have, as such, all residents of Ohio's nursing homes and residential care facilities have the right to participate in resident and family councils and their loved ones in family councils. So what do resident and family councils do? They meet to discuss and offer suggestions about policies and procedures affecting residents. They provide support to each other. They help plan resident and family activities. And they help participate in educational activities, and also for any other purpose. The main goal of most resident and family councils is to improve the quality of life for residents of the home. In a future fieldwork assignment, you'll ask the resident council president of a home if you can join a meeting. During the meeting, you'll observe the council proceedings and take notes on what is discussed. More to come on this later. That concludes the end of this module. Thanks for watching.